Patellofemoral pain is an umbrella term used for pain resulting from the patellofemoral or kneecap joint. The patellofemoral joint is made up of the kneecap, which is held within a groove on the front of the thigh bone by the quadriceps muscles and tendons and several ligaments. And any of these structures can contribute to pain, which is commonly felt at the front of the knee. Another term used, therefore, is anterior knee pain. Patellofemoral pain is common in adolescents who participate in repeated, high-intensity and higher volumes of hopping, jumping and change of direction type activities, but it can also occur in those who are less active and in adults too. They usually present with a gradual onset of pain in the front of the knee that gets worse with activity and settles with rest, although many patients find prolonged sitting with the knee in just one position also aggravates their pain, and it's been known as cinema or moviegoer's knee. Some children may experience swelling around the kneecap. The knee is often noisy or clicking or grinding, but despite not sounding great, it's not related to pain levels and certainly doesn't indicate that the tissues are damaged. The pain is often in both knees and easily aggravated by activities like squatting, lunging, walking, or running down hills or stairs. The kneecap can be irritated when it gets compressed in positions such as kneeling, sitting, or wearing tight, skinny jeans. And also different footwear can affect the knee pain. It can vary between high heels for some people, or in others, very flat shoes which lack support can also contribute to symptoms. Everyone is different. Patellofemoral pain needs to be diagnosed by a health professional who's got experience with adolescents, who'll know what signs and symptoms to look for and be able to diagnose the condition without x-rays or scans. They'll ask lots of questions about the symptoms and how the pain behaves. And they'll ask the child to do a series of movements to isolate what structures are contributing to their symptoms and give them advice and exercises about how to self-manage their symptoms. In some people, the symptoms settle really quickly and then just recur from time to time, but in others, the symptoms may last for prolonged periods of time. The management approach will therefore vary according to factors such as how long they've had their pain and other factors such as sleep quality, general health, and psychological well-being at the time that they get their symptoms. Firstly, let's deal with many of the unhelpful messages that flood the internet. Many children will tell their parents about the fact that their knee is still hurting, and many will be told just give it a few more days rest. They may go to the GP and be told to rest for 2 or 4 or more weeks, but that is rarely going to help them get better. The less they do, the less they will tolerate, so it's obviously not the right solution. Another message that's not helpful is that adolescents will simply grow out of their pain and should just wait until that happens. And whilst for some that may be true, waiting until they've stopped growing might be years away, and it's neither practical nor a wanted solution. If we give adolescents with knee pain the right advice in the early stages, there's no reason why they can't get on top of their symptoms and enjoy an active adolescence. One of the priorities that children have identified in studies that helps them manage their knee pain is to have a diagnosis that they can understand that does not provoke fear and explained in words that they can use to tell others. They need honest advice about how long to expect their symptoms to last and how to self-manage and take control of their symptoms. Adolescents with patellofemoral pain are more likely to reduce or stop sports participation, so we need to support them to stay as active as possible. The less they do, the more the muscles will decondition and the less tolerant they'll become of load. However, it's important that they don't aggravate their symptoms more. And so usually, if we give them this set of guidelines, it will help them to understand when they can play and when they shouldn't. They should only create a mild pain. And that's difficult for children because actually when they're playing, they often don't recognise the pain and it's only afterwards that they realise it was sore. So an easy one to add into that is that it shouldn't cause them to limp or change the way in which it moves. And it should also settle within an hour. It should be no worse the next day and it shouldn't cause any increase in swelling. If their pain is greater than a 2 or 3 out of 10, then they might be able to settle their symptoms by using either ice packs or applying a simple tape or knee support. But it's important not to give them painkillers to help them to get through a game, as this will mask the pain and is likely to make the whole condition last longer. Appropriate strength exercises may also help to reduce pain and give the tissues greater resilience under the supervision of a healthcare professional familiar with treating adolescents. If the pain is persistent, they may need to cut down on what they're doing, and they could take 2 to 4 weeks off from all high-impact activities such as jumping and running to allow the symptoms to settle. After the pains settle, they shouldn't return straight back to the same high level of intensity sport that they were doing when they got their first symptoms. They need to build back up gradually so that their bodies can adapt to what is being demanded of it and gradually get themselves stronger. To help them get back to sport, try using the Kids Back to Sport toolkit. Find a level of activity on the steps that they can do with only minimal pain and that settles quickly without causing more symptoms the next day. For example, they might be able to go on their bike but not run, or they may be able to jog but not sprint. When adding new activities back in, leave a day between exercise sessions to assess if there's been any adverse reaction, and then repeat that exercise once more before moving up the steps. If there's no increase in symptoms, they can move up the steps one level and repeat the process. It may take several weeks or longer to achieve their previous level of activity, but this allows the immature bone to become stronger and tolerate more load ultimately, and reducing the risk of recurrence. Once they can run, they're not yet ready to go back to sport. They need to start to replicate all of the different activities that they'll be subjected to once they return. We need to start to add changes of direction, stopping and starting drills, and build up the number of sprints they do to replicate the demands of the sport that they play. In the early matches, limit their game time and allow a day between matches so their body can adapt to the new stresses being applied and get stronger. If we want to prevent the pain recurring, we need to educate the child and their parent about why their symptoms developed. Patellofemoral pain is often aggravated by a spike in activity relative to what they've trained for, such as happens at the beginning of a school year or new season, when their step count or activity level spikes. They'll exceed the current capacity of their immature body, and that might be because the child did too much too soon, or they may have had a drop in their capacity due to a recent virus, a growth spurt, or a lack of adequate sleep or nutrition. To learn more, watch the Kids Back to Sport video on why kids get injured. Patellofemoral pain is much more difficult to explain to a child than, say, perhaps when they sprain a ligament. We need to explain to them how the brain perceives pain. The brain decides when it needs to protect us based on information from our environment, our beliefs, our past experiences, and our current emotions, anxiety levels, stress, or sleep. It's complex. If the brain decides it needs to protect us, it switches on pain, just like sending a text message to warn us that we don't have the current capacity to tolerate that activity just yet. It's just a message. It's not an indicator of tissue damage. Once the danger has passed or the signal downgraded, they can turn the volume of the pain back down, and given the right management, these children manage their symptoms well and remain actively involved in their sport. For a number of children, however, their pain persists. Those more at risk of persistent or recurrent pain are commonly female, non-sporty adolescents who experience more long-standing and frequent pain at the outset. In some children who have a diagnosis of autism spectrum disorder, ADHD, and hypermobility, symptoms may be more prolonged. Equally, those who have current low mood or anxiety may also get more long-lasting pain. These children need education to understand how chronic or persistent pain works and how they can learn to manage it. We describe pain as merely being a messenger from the body to let the child know they're exceeding their current capacity. They can be taught to see that pain is not an indicator of tissue damage, and that unhelpful beliefs such as exercise will cause further damage are simply not true. The messaging signals should stop once the danger is over, or the child recognises that what they thought was a risk after all isn't. However, for often complex reasons combining wellness, emotions, psychology, and many other factors, in some instances mean that the messages continue to bombard the child and create a vicious cycle of pain, misery, and a reduction in activity. We need to remind them of the way in which the brain can get stuck, such as when they hear an annoying song in their head, and the more they try to forget it, the more it is there. They may begin to see that the song has got stuck on full volume. But how, now that they understand how their pain has occurred and how exercise helps, not hinders, they could use that same analogy to turn the volume down on their pain and start their recovery process. They may be able to see how to distract themselves and shift their thoughts so that they can control the volume of pain with the right strategies. Giving them tools to self-manage their symptoms and help them boost their capacity through improved sleep, good nutrition, and tools such as cognitive behavioural therapies can give them greater control over their pain volume and help them get safely back to the activities they enjoy. These types of conditions can last for many months if not treated appropriately. So if after trying to reduce their symptoms down, your child is still in pain, it is often helpful to see a health professional who has experience in treating young athletes. Not all practitioners have the knowledge or expertise to treat children, so check those listed on the Kids Back to Sport register or ask your local therapist whether they treat children. Download the booklets on why kids get injured at the Kids Back to Sport website and learn more about how to get your child safely back to sport.